Hi, my name is Jamie Edmonds. You may know me from my 20 years in TV news, more than a decade at WDIV in Detroit. I'm Jamie Edmonds. Or you may have heard my voice for the past 3 years on the historic WJR 760 on the morning show. It was so fun to wake up Sunday morning, get ready, watch this game. I have told other people's stories for years. It's time to tell my own. I was diagnosed with breast cancer in February 2026. I am in the thick of the fight. Since that terrible phone call, angels have propped me up and supported me, starting with the two in my household, my husband Ryan and my daughter Olivia. Then the circle expanded to so many people, so many angels helping me get through this. That's why I named this podcast Angels Along the Way. I will talk to folks who treat this awful disease, those who console, those who assist, and those who inspire. I hope this helps anyone and everyone on a similar path. Episode 2 of Angels Along the Way. I'm going to say this person is a future angel of mine because she is Dr. Jessica Bensenhaver. She is going to be my breast surgeon when the time comes. And Dr. Bensenhaver, we met briefly. I call it the dark time because that was right when I got the diagnosis. So I don't quite remember all the things you said in that first meeting.
Hi, thank you for having me.
I am so honored to have you on this podcast. We're going to use my case as sort of the basis to start discussions, but I think I want to expand it to all the different kinds of cancers. We can maybe stay breast cancer, however this conversation takes us. But I really want everyone to feel seen and heard, and that's the point of this podcast.
I love it. Let's get started.
All right, let's get started. Let's first get to know you, Dr. Bensenhaver. I know you have that Michigan connection, which certainly has a lot of people feeling seen right now. They love Michigan. But talk to us about where you got started, where you grew up, and how you got to this place.
So I was actually born and raised in very rural West Virginia. My dad was a general practitioner. He did everything from pediatrics to geriatrics and everything in between. I kind of joke that he's kind of like Dr. Quinn because he did it all. And that was the life I grew up with. So I saw what he was able to accomplish. I very quickly, I would say in life, knew that I wanted to be a physician of some form or fashion. And then as things progressed, I found myself as a breast cancer surgeon. And I came to Michigan to complete my training. I was at the University of Michigan for fellowship, and I stayed on as staff for about 5 years. And then transitioned to Henry Ford, where I am now. And I'm the director of the Breast Oncology Fellowship, the division head for surgical oncology there. And that's how you and I met.
I find Henry Ford extraordinary because you meet a lot of people in those first early days. It's like you have your team that descends on you, and you're part of my team, even though in my treatment, I'm starting with chemo first, and then I see you for surgery later.
Right. So that's what we call multidisciplinary care. I am part of a team of physicians that treat breast cancer, and that includes not only surgical oncology, but medical oncology, radiation oncology, and every extension of that exists, clinical trials, breast imaging, breast pathology, all breast specific. And we're all part of one team that meets every week and discusses every patient that comes in, either internal, external, second opinions. And we have all sort of collaborated together to create a group of people that treat one disease, that are always talking and interacting about what's the best way to treat this particular patient, because there are processes, there's protocols. It's very biology specific, patient specific. But because surgery is usually the vast majority of the time a part of the patient's care, that's why you see me often first, is because the surgeon kind of is the one that sort of dictates, hey, this is the case, here's what we need, where do we go from here? And that's where the whole team comes in together. So that's why, yes, we did meet up front very briefly, but because of the situation with your case, we knew that we needed chemotherapy first. So we went briefly and then very quickly transitioned you onto the medical oncologist. She and I are always in cahoots, always talking about progress, where we are, how things are going. And then once she's near complete, you'll move on to surgery, which is when you'll come back and see me again.
So, why do some people have surgery first and others not? My guess is, through the mild research I've put out there, is that it's the type of cancer that kind of dictates that. And the kind that I have is triple negative.
Right. So, there's actually two different reasons. Absolutely, cancer biology is one of the driving factors. And in your case, yes, being triple negative and being of a certain size, we start with chemotherapy. One of the things when chemotherapy first became an option, initially it was because we were trying to accomplish what we call downstaging, meaning we were taking a big tumor and making it a smaller tumor and creating more surgical options for the patients. For example, taking them from only being a mastectomy candidate to being a lumpectomy candidate. But breast cancer is always evolving. I can tell you that from the time I started doing this, which now, ironically, I'm 15 years into just being a breast cancer specialist. When I just started doing this, that was oftentimes the goal, was just downstaging, making the patient a lumpectomy candidate that was previously a mastectomy candidate only. But as time has progressed, we've learned a lot of things about breast cancer. It's not one disease, it's a spectrum of disease. And you have super aggressive tumors, super lazy tumors, and everywhere in between. And with the super aggressive tumors, we've learned that yes, they respond beautifully to chemotherapy, but that response at the time of surgery, which we can see once the surgical pathology is looked at, really dictates long-term outcomes and helps us to decide what a patient needs after surgery. So now, any patient that comes in as triple negative or what we call HER2 positive, that's another receptor we look at. We have to look at that case and decide, is this a case where we don't do chemotherapy first? Because doing it first gives us information about what we need to do long term. So even if it's an early stage breast cancer, if it's triple negative or HER2 positive, and sometimes other biologies, which we have tests that can tell us whether or not they actually need chemotherapy first. Those are the ones that, even though they are potentially small up front, we still do chemotherapy to begin with because we need to see how they respond.
In my minimal research, because I've done that on purpose, I don't want to Google. Dr. Google, which I do remember you saying that day, is
Don't
not your
Dr.
friend.
Google.
And in fact, you said breast360.com was like a safe place to go if you want to learn more, right?
Right.
Okay. So I really haven't done much, but I did do a little research for our interview here. And it's like, okay, you want to shrink it, but you also want to see how it responds to the drugs for what you might do in the future. And that makes total sense now.
Yeah, absolutely. And Breast 360 is a great website that I actually refer all my patients to. It's created by the American Society of Breast Surgeons, so it's the kind of governing body for breast oncology, or surgical, I should say, surgical breast oncology. And it's a website created for patients that gives you information about everything breast, benign, malignant, everywhere in between. But in particular for my breast cancer patients, it really brings it down and brings it home so you can understand where you are in the process, why your case is unique, and with your recommendations, what is going to be your kind of driving forces for your treatment algorithm.
All right, let's go back to the beginning. So I had a clean mammogram in July, but I have very dense breasts. And the 2 or 3 mammograms that I've had, I would get these letters to my house saying, okay, you're clear, but you have dense breasts. And I'm like, okay, what am I supposed to do with this paper? Now what? Like, if my doctor doesn't prescribe anything more, great. Thank you for telling me. But should there be more done for people like me who get those letters?
So I love that you brought this up. So I'm going to start with breast density. So when we look at mammograms, there was a case years ago where a patient similarly had a negative mammogram and a locally advanced breast tumor. because her breasts were so dense, it actually was not seen by mammogram. It could be felt, but not seen. And because of her, the laws were changed, and I think this is fabulous. The laws were changed so that breast imaging has to report your degree of breast density, and I dare I say vaguely what that means. So if you are extremely dense or heterogeneously dense, they have to say this could mask an underlying mass because you are so dense. Now, absolutely no questions asked. Mammogram is the best source of screening. 100%. I recommend starting at 40 years old. I recommend annually. Depending on what website or what society's recommendations you look at, those recommendations can vary. But at Henry Ford, we recommend annually and starting at 40 for the general population. If you are high risk, that's a whole nother conversation. But if you think you're high risk, reach out to our team and we'll figure that out. But general population starting at 40 and with mammogram. But mammogram is not perfect. And again, if you have heterogeneously dense or extremely dense breast, it can hide masses. So yes, it is reported you have dense breast. This could mask things. So what does that mean? I think it's great that it's reported, because when it wasn't reported, then women had no idea. Women that had fatty breast versus extremely dense breast, they had no idea they fell in different categories. Now they do, but I agree with you. It's like, now what do I do with that?
Right.
I would say to anyone listening, if you get a mammogram report that says you're heterogeneously dense or extremely dense, talk to your PCP, your GYN. If you don't have one, reach out to a breast center and just say, hey, this is what my report says. What does this mean? What should I do? We are absolutely recommended to do something we call risk assessment. So for somebody that has extremely dense breast, even if they don't have a family history, there's an algorithm we can follow to decide, does this patient need additional screening or more sensitive screening, something to potentially avoid missing a mass on mammogram. And in your case, yes, you were extremely dense. So there are situations regularly.
By the way, extremely dense is like not cute. That's not a cute term. It doesn't sound flattering.
So this is a podcast. So when I see a patient in person versus like something that's going to be aired potentially worldwide, I'm a little bit more hesitant about how to describe it. But extremely dense basically means that your breast is very glandular as opposed to fatty. So as we age, as your breasts develop, it's glandular breast tissue. Those glands are what creates the lobules and the ducts and the things that create the breast for what it's made for. As we age, that glandular tissue becomes fatty tissue. Every person develops that differently. So if you have what's called fatty breasts, that just means your glandular tissue has become replaced by fatty tissue, a totally normal process. And it's a good mammogram, right? You can see it. Any mass that develops, it's right there. If you have an extremely dense breast, that just means that the bulk of it is glandular, not fatty. So in essence, for lack of better terms, your breast is that of a younger person, right? Because it doesn't have all of that fatty change.
Great.
Exactly. The caveat is that it can hide a cancer.
Is it possible that it was there in July and it couldn't be seen? Or do you believe from what you've seen that it maybe grew in those 6 months?
So two answers to that question. One, yes, it could have been there. Because you do have extremely dense breast, it could have easily been masked. But it's also a triple negative breast cancer, which is one of the more aggressive, faster growing breast cancers. So it could have happened in that interim. So we call those, when you have a negative mammogram and then the interim of development, we call those interval cancers. And it's one of two things, and it can be a combination. If it's a dense breast, it can be hidden. But if it's a fast growing cancer, it can happen in that 6-month interim. So pretend you had what we call a fatty breast or a very low glandular tissue breast. It may have shown up in that initial, very small, it may have shown up, but there's no way to know. So that's why we always say, yes, get your mammogram, 100% yes, get your mammogram. But also too, if you feel something, don't assume that a negative mammogram means it's okay. Still get it checked. I do think there could be better communication about, hey, you have on that report, like you said, hey, you have dense breasts. It could mask things, but what does that mean? Perhaps we could say, talk to somebody and see if you feel something, make sure you still say something.
Mm-hmm.
Because those are what we call interval cancers. They grow in the interim of that mammogram screening. And it's because, again, a combination, dense breast, aggressive tumor. You can have tumors that can be there for years and you never see them. You can have aggressive tumors that are there for, I've had patients that have a negative mammogram that have a fatty breast and 3 months later have a golf ball sized tumor. That's tumor biology. That's not the mammogram. But in your case, you have that extra variable of the dense breast. So could it have been there? Sure. Is there any way to know? Not really.
Okay, well then that's the first takeaway for this podcast is to still get those mammograms. They are valuable to doctors, but also do those self exams.
Sure.
And that's another thing I talked about with my friends because we're talking a lot about breasts this time because I'm one of the first in the group that has this. How do you do a breast exam? What are you feeling for? I mean, can you talk it through in a podcast that's not like, we're not going to do a
Yeah.
demonstration.
Sure. Yeah. So I often tell patients first and foremost, it can be affected by the degree of hormone input you have. So if you're premenopausal, you want to try to do it at the same time of the month every month when your hormone level is at the same level, because when your hormone levels vary, your breast density varies. That's why they say, right before you have a period, you can have breast pain or your breasts feel heavier. You want to try to do it at the exact same time. So what you're feeling, you can compare. I also tell patients to try, for whatever reason, it's easier to do it in the shower. If you're in the shower, I don't know if it's just like the water, the moisture, but it's easier to feel the entire breast. And you can either do it circular, where you start in the middle and kind of go all the way around, all the way to the outside, or you can do it radial, where you just keep coming in and just make sure you feel every point and every portion of the breast. I do recommend not doing it more than once a month, because if you have a change, it's going to be less obvious to you. So I always say, like, if you want to pick a day, pick a day. For postmenopausal women in particular, pick the first of the month, or the first day of your period or the last day of your period. The hormones are less at the end. So if you say, okay, if my period starting is day 1, on day 7, regardless of how many days you bleed, on day 7, I'm going to do this exam. That helps you to keep it consistent and be able to compare one month to the next.
Great. There's another takeaway for people listening. Another thing that I didn't put in my questions to you that I do have a question about is that there was a little bit of, earmuffs to people who might think this is, kind of gross, but there was some leakage that I ignored. And I feel like that could have been the first sign of this because I have the ductal carcinoma. Is that something I should have called a doctor about?
So yes and no. What you're describing is what we call nipple discharge. And there's 2 types of nipple discharge. We call it either physiologic or pathologic. And there's some things we look at to determine whether it's one or the other. So physiologic is typically multiple ducts, both breasts, sort of either a yellowish or greenish color, and what we call non-spontaneous, meaning you have to actually compress the breast to get it to come out. Pathologic, so pathologic meaning one, like a type of discharge we're concerned about, is when it's one side, one duct,
Okay.
potentially bloody.
No, actually.
Yeah. And then if it's what we call spontaneous, meaning it happens on its own, not when you compress the breast.
Yeah.
And if it's what we call pathologic, to me as a breast surgeon, that means I need to look into this and make sure that it's not a reason of concern that it's happening. So yes, if there's any question, you can ask your PCP, your GYN, and if you're not getting clear answers, just find a breast center and find a breast specialist. We have a vast team of not only surgeons but nurse practitioners, and they'll tell you this is physiologic, it's fine. This is pathologic, we need to look into it.
Okay. All right. There's a third takeaway. Let's talk about the different kinds, because before all of this, pre-February 10th, I thought it was just breast cancer. But now I'm hearing there are subtypes, and the kind that I have is different than my couple of my friends who I've connected with. Are there the 3 kinds, or are there more than that?
So there's more than that. So the most common type of breast cancer is ductal. The second most common type is what we call lobular. And then there's a combination of subtypes that are less common but still happen and we still see regularly. But within those categories, we also see different varying degrees of aggressiveness. So, for example, ductal, the most common, you can have highly aggressive, you can have extremely lazy, and they're treated totally differently. Similarly, with what we call lobular, lobular is more, it's a less common, it's the second most common type, much less common than ductal, but it's what I refer to as a sneaky, as I call it sneaky, because it doesn't create a mass per se, it sort of infiltrates through the breast tissue. And similarly, it can also be high grade or low grade, so really aggressive or really lazy and everywhere in between. So depending on where it falls, dictates the type of treatments we recommend. So I guess from an overall perspective, I think the biology is really what drives our treatment recommendations, meaning high grade, low grade, receptor status. But certainly the type of breast cancer, ductal, lobular, and the vast majority of others really is dictated by the biology. So I always tell everybody there's a spectrum of breast cancer that goes from extremely aggressive to extremely lazy and everywhere in between. And all of those can include different types of histologies, meaning ductal, lobular, and all the other ones.
If mine is not hormone receptive or HER2 positive, does that change the after maintenance?
Yes. So for triple negative breast cancer, if it's at least a certain size, we typically start with chemotherapy first. If it's extremely small, then there are certain situations where yes, we do surgery first, but we oftentimes start with chemotherapy, then go to surgery. And then really important information from surgery is the degree of response to the chemotherapy. If you have what we call a pathologic complete response, which is what we want, which means that all of the cancer cells have been completely melted away in the breast, in the lymph nodes, if it was in the lymph nodes, if everything that we saw is now gone, that's great information, which dictates what we do next.
Okay.
If there is still residual cancer, then we know that there are improved outcomes for what we call adjuvant systemic therapy, meaning different additional chemotherapy, usually oral, given after surgery. So if that's the case, if there's still residual disease, then your medical oncologist will talk to you about doing more systemic treatment. If it's completely melted away, then most of the time we just move on to what's next. So in the setting of breast conservation, radiation, in the setting of mastectomy, typically it's just surveillance.
Okay. And that is something that my doctor has started to prepare me for, that could happen, that you have to take an oral drug after everything. And I'm like, well, man, that stinks. But
Yeah.
she said the side effects are not the same as if you're getting it in your port
Correct.
every week. Okay.
Very different side effects. And it's really driven by your response to the neoadjuvant chemo that you're getting right now.
Okay. Well, here's to hoping that thing is shrinking inside there. Since I've started to be public about my story, I've gotten a lot of people reach out to me. I've talked to a 31-year-old mom who was breastfeeding when they found this. I've talked to sort of people in their 20s. And the stories of that are out there, the famous people like Olivia Munn and all this. These are young people. Why is this happening, especially in people that don't have the gene? It doesn't seem to be genetic. What are we doing to ourselves?
Yeah. So there's a lot of factors that go into that. I would say first and foremost, one of the things that I learned very early is that in patients that appear to have a genetic predisposition, it's about 20% of the patients we see. But of those 20%, only 10% have an identifiable gene. So it doesn't mean that it's not a genetic predisposition. We just don't know what gene we're necessarily looking for. So, and that's one of the reasons why risk assessment is really important. This isn't for cancer patients. This is for non-cancer patients. But if you have a family history a significant family history, see somebody and have a risk assessment done, because it's entirely possible that outside of a known genetic predisposition, you're high risk and you should be screened in a different way. But in addition to these genetic predispositions that we may or may not know about, we know that there are other things happening, that environmental factors, 80% of the cases we see are spontaneous. But I think too that there are just things that we don't know that are making these happen. But also too, we're much more open about these things and seeing them and these being diagnosed. I mean, if you look back years ago, you didn't necessarily know it. One of the most poignant cases that I've ever had was a patient that was extremely young. She was BRCA positive and didn't know it because she had a family member that was diagnosed like generations back. That was diagnosed at an extremely young age and passed away, but nobody knew it was breast cancer.
Mm.
So it wasn't that the genetic history wasn't there. They just weren't aware of it because people didn't necessarily talk about it. And so we're kind of at this point in time where it's all coming to light and people are talking about it. It's not looked at as a stigma. So I think it's a combination of multiple things. Environment can be part of it too, but genetics is certainly there. And I do think that talking about it, bringing it to light so people aren't ashamed or don't think it's something that should be hidden is really important. And what you're doing, I think, is huge for that.
Well, I like that aspect of it, that we can talk about it. I mean, we're on a podcast talking about it, and a long time ago, I don't think that would happen. So I think there's value here in the people that are going to be listening. I just know that all of my friends are looking for a way to protect themselves, be proactive. And a lot of them are doing all the right things. And sometimes, like it happened to me, it happens in between mammograms.
Yeah. I would say for all women, certainly if you think you could be at high risk for whatever reason, family history, if you just have lumpy, bumpy breast, if something just doesn't feel right, talk to your PCP and see what they have to say. And if they are, not certain, then find a breast specialist. I have no problem seeing somebody that's like, hey, I just want to know where I'm at, where I fall, and is this important? But certainly for the general population, mammograms at 40.
Mammograms at 40. Okay. And I've gotten some messages from people who have listened to the story and they're like, I'm going to go get a mammogram. I'm like, great.
I think something else worth bringing up though, too, is if you feel something, don't assume it's okay if you're not 40. Just get it checked. I mean, I regularly see patients that have benign breast masses that are like, I felt it. I've known it's there forever. And then all of a sudden it started growing. I will tell them, I love that you've been proactive. I love that you're here. But if you can tell anything or educate anyone, when you feel it initially, just come be seen. Don't wait. And oftentimes those are benign breast lesions, which are, fine. We can manage those either by observation. Sometimes we have to remove them. But if you feel something, just ask. No one in our team or any team that I know of will ever say that that's not appropriate.
Okay. The new saying, instead of see something, say something, it's feel something, say something.
Feel something, say something. Yes,
right.
Absolutely.
Okay. I have questions about radiation too, because I passed the floor at Henry Ford where radiation happens.
Yep.
Who are the people that get radiation? I know you're going to say case by case, but who needs it?
Yeah, right. But yes, case by case, but there are some very standard protocols. So any patient, I'll give you a little history here and you can decide what to do with it. So back in the 80s, when lumpectomy became an option, previously mastectomy was it. In the 80s, they did a study looking to see if lumpectomy was an option. So they compared mastectomy to lumpectomy with radiation to lumpectomy alone. And what they discovered was that lumpectomy with radiation equaled mastectomy when it came to overall survival, right? And lumpectomy without radiation had a much higher in-breast recurrence rate. So what that kind of told us was that radiation really did help with the local control component and made lumpectomy equivalent to mastectomy. Fast forward. Now we know that biology really, and as we've talked before about biology really is what dictates the need for chemo. Biology really dictates a lot in breast cancer. So for really indolent tumors, do they necessarily need radiation? Maybe not. So we looked at older women with these more lazy tumors and figured out through studies that there are some cases where for overall survival, they don't necessarily need it. But what I make sure every patient knows that at this day and age, today, if you get a lumpectomy operation, that radiation is going to be something that we talk to you about. Because again, we know that radiation is what helps make lumpectomy equivalent to mastectomy when it comes to overall survival. There are certain cases where we can omit it safely. So women over 70 with indolent breast tumors, there's a trial that actually just closed looking at women 50 to 70 with indolent, sort of lazier on the lower end of the spectrum breast tumors. We don't have those results yet. But for all comers right now, I would say if you're getting a lumpectomy, be prepared to discuss the role of radiation in your case. All right, so that's
avoid radiation if you get mastectomy.
I'm sorry?
Can you avoid radiation if you go the mastectomy route?
So in the setting of mastectomy, there are two big indications for radiation. Number one is if your tumor is greater than 5 centimeters. We are going to send you to radiation to talk about the benefit. Even if your lymph nodes are negative, if your tumor is over 5 centimeters, we're going to talk to you about the benefit of radiation. Secondarily, if your lymph nodes are involved in the setting of mastectomy, you're going to be sent to radiation to discuss the benefit. There are certain situations where we may or may not recommend it, but a tumor over 5 centimeters and lymph node involvement is going to at least get the discussion. Now, we could talk about this forever, and we can talk about like the input of neoadjuvant and downstaging, but I think what's really important for people to understand is number one, in the setting of lumpectomy, you're going to discuss radiation. You may or may not have to get it, but the vast majority of patients are going to need radiation in the setting of breast conservation, the lumpectomy operation. In the setting of mastectomy, it comes down to tumor size and lymph node involvement. If the tumor is greater than 5 centimeters or if the lymph nodes are involved, you're going to get that conversation.
Cool. So we'll have that conversation sometime soon because I have lymph node involvement.
Yes. But if you downstage, meaning if those lymph nodes become negative, we'll see.
Okay. We'll see. Just, a couple more here. I just had the question about, is there a standard of care? If me, Jamie Edmonds, with all of my biology and everything going on, went somewhere in California, would the care be the same? Or is there discretion of doctors like yourself?
There is definitely an overarching standard of care. Everything that we do in breast cancer management has data, research, clinical trials behind it. I can tell you that I started doing breast cancer only in 2011. And the protocols, even since then, have changed to a degree that I can't even describe. And it's all based off of research and data and ultimately patient outcomes. What is best for the patient? So yeah, and I will also say that I think second opinions are really important because I think that helps reassure patients that, because this is something new to them. Yeah, I do this every day, but this is new to you. Getting a second opinion is never a bad idea. And we regionally do it regularly and nobody cares, nobody takes offense because it reassures the patient that what they were recommended is what's great, the best option for their case. So yes, we follow protocols, processes, data, and research driven nationwide.
Last question from me, definitely, and then I want to get
your questioning because that, if anything, will give you reassurance.
And that's actually what happened to me because I went and got a second opinion and they said, well, it's the same care. And I felt comfortable with who I met on that first day. And I was like, let's go. Last question for me, and then I'd like to get into some questions that I got for you from some listeners. My last question is, now I'm afraid of everything, and I'm afraid of ovarian cancer and lung cancer and everything else. Am I predisposed now for something else to pop up?
So genetic testing is really helpful in determining if you have a genetic predisposition to those other malignancies. Outside of a genetic predisposition, like what we are told is to treat you as no. Like if I have a patient that comes in that has everything that suggests a genetic predisposition, but it says no, I will watch you, I will follow you, but no, not you don't have those predispositions to other things. Now, if you have environmental factors, like say you have secondary exposure to smoking on the regular, well, certainly that's going to put you at a higher risk for lung cancer than somebody that doesn't have that, either primary or secondary exposure. But from a lifestyle predisposition, no. It's, again, 80% of the time, it's a spontaneous thing.
I don't want it to pop up again. This has been quite an ordeal. And even though I can talk about it now and I'm trying to help people, it's still a very scary time.
Yeah, and it's a marathon. It's not a sprint. I always tell patients, I always see patients back near the end of chemotherapy, about a month usually before the end, and I always tell them, the light at the end of the tunnel is coming. It's not there yet, but it's an intense experience. Nobody deserves it ever, and I tell people every day I would certainly find another job if I could cure everyone of breast cancer in a millisecond. I would do that. But I can tell you that at the same time, we are every day working to do better, to be better, to improve patient outcomes, to treat appropriately, to not overtreat, but not to undertreat, and to figure out exactly what every patient needs so they're getting what their tumor needs. They're not getting too much, they're not getting too little. And I'm telling you that every 6 months, I feel like we are changing and for the better and learning and just doing things in a way that even when I started doing this were things that I never even thought possible.
Yeah. Well, I do feel grateful it's 2026 and you and your research and all of that. And collectively as doctors is where it is. And I'm at this point and you're caring for me. A couple questions from people. One question from Amber saying, with having triple negative breast cancer, what are the pros and cons of having a lumpectomy versus a double mastectomy, which we have gotten into? But she says, like, what if it's your sister? What would you tell your sister to do?
This is a loaded question. So I want to start with saying that there is a ton of data that tells you that tumor biology does not dictate surgical recommendations, meaning that an aggressive tumor does not necessitate needing an aggressive surgery. So assuming this patient is not genetically predisposed, so we're not looking at a risk reduction component to a more aggressive surgery. The actual cancer she has does not dictate which type of surgery. If it's a small tumor or if it's a downgraded tumor, if she's a lumpectomy candidate, she's a lumpectomy candidate. If she's only a mastectomy candidate based off of tumor size, or if there's what we call multifocal, multicentric disease, meaning spots kind of throughout the breast, then that's a different story. But if she's a lumpectomy candidate and she's not genetically predisposed, there's no reason to dictate, to recommend mastectomy over lumpectomy.
Because that is a much bigger surgery and recovery.
Much bigger surgery, much bigger recovery. And from a cancer perspective, it doesn't have an overall survival benefit. If it were my sister, I have 3 brothers.
Hypothetically.
But hypothetically, I have a lot of friends that I consider sisters. I would tell them the exact same thing, but I have information and knowledge to an ad nauseum, right? So I could comfortably go to someone I view as a sister and say, hey, I'm telling you, you're a lumpectomy candidate. There's no survival benefit. You don't have a genetic predisposition. It's a great option for you. But if you feel like you need a mastectomy for peace of mind or for, just to make you feel like you don't face everyday questioning it, then that's also reasonable. But from a cancer control perspective, if you are a lumpectomy candidate, then there's no benefit to mastectomy over lumpectomy.
Okay, and just one more question from Deborah. She has a daughter who's young, 36 years old, has a young son diagnosed with breast cancer in February. So, just like me, going through treatment. Is it recommended once you have the surgery to do the reconstruction right away or add implants? So, infer what you want in that question.
Right. So, the recommendation for reconstruction typically has to do with cancer stage at presentation, and response to treatments. If we can, if a patient is interested in reconstruction, we always want them to have it in the immediate setting, right? So they go to sleep, we do a mastectomy, we remove all the breast tissue, we leave the skin, we leave the nipple if appropriate, and they wake up with the reconstruction. But there are certain situations where we recommend delayed reconstruction, and there's kind of a handful of reasons. But I would say that most providers are very clear, and most providers are very clear from the get-go. We need to see how you respond. And if this happens or if that happens, we can consider immediate reconstruction. But you need to understand from the get-go that you may be a patient or a case where delayed reconstruction is what's recommended. But if it's a situation where the patient is looking at a smaller tumor and for every rhyme or reason could be immediate reconstruction, absolutely do it. Absolutely do it. If it's not a cancer control problem, right? Because always our priority is treating the cancer, right? Cosmetic is second. Primary is treating the cancer. So if there's not a reason that the cosmetic component is going to affect the cancer treatment, then we tell them that they can be immediate reconstruction candidates. Some patients don't want it. And if they don't, that's totally fine too. There's a huge push a couple years ago about going flat. And if that's what the patient wants, fine. But if the patient doesn't have a cancer control issue or cancer treatment issue, absolutely, immediate reconstruction is something you can do.
There's a lot here. I think it's been very valuable to those listening. On a lighter note, I mean, what do you do for fun? What do you watch on TV? What are you reading?
Oh my gosh. All right. So so that's a lot. There's so many questions. Okay. So on TV, my mom got me into Outlander, and currently season 8 of Outlander is on. So I have been watching that. I may have just lost friends. I don't know. I can also tell you that one of the radiation oncologists that I work with loves it too and comes in very excited about it. So that's some way we have that alongside of cancer treatment. We have that to talk about on the regular. From a reading perspective, my husband got me into Abraham Varghese years ago, and Cutting for Stone is by far probably my favorite book. And I just read it again for the second time.
Oh, wow. You love it.
Oh, yeah. Yeah. And I don't have a lot of extra time, so it does take time, and it takes me a long time. He also had Covenant and Water that was excellent. But yeah, that's probably my favorite author / book. And my current television obsession. But also, I just got into Homeland, which is old.
Yeah, but great.
Really old. And I'm on season 2 of 10, I believe. But that was another good one.
Excellent. See, there's like the 15th takeaway. People have got book and TV recommendations as some of us are going through treatment. So that's valuable.
Yeah. Download it, watch it in the chair, go for it. I'm telling you, like, it's, you know what? I'll give my brother a push. My youngest brother was diagnosed with leukemia about 4 years ago and underwent treatment, and it's pretty intense. And he was like, what can I do while I'm doing this? I was like, find a show and just binge watch it.
Yeah.
And I kind of he did that and he really enjoyed it. And I've kind of followed in suit. I never did it before, but he was like, you got to binge watch. So whenever I can, I do.
I actually binge watched Virgin River, and there's a rural doctor on there, which when you were talking about your dad on the show, it's Dr. Mullins. Reminds me of what you were talking about.
Dr. Mullins, I didn't know that many people knew. Dr. Mullins absolutely reminds me of my dad.
Yeah.
That is his MO. I'm telling you. I grew up like one of my favorite things as a small kid is when a particular patient, and I have no idea who it is, would bring him, they called them haystacks. They were like these caramel, chocolate caramel dessert cookies. And whenever my dad would come home with haystacks, it was going to be a good day, but it was patient dependent.
Well, I really appreciate your time, Dr. Jessica Bensenhaver. You are a future angel of mine. We'll talk about future surgeries. I'm not there quite yet. I have a couple months left to go. But again, I appreciate you on this particular podcast. I'm trying to connect with people and help people. And I think you did that today.
Wonderful. And I really appreciate the opportunity. Like I said, I think getting it out there, people making it a common conversation, not wondering or thinking or not knowing what to do, it's huge. And it's really what's gotten us where we are today. We've had a lot of progress in many ways, but just making it something that's not a stigma has been huge. So thank you for the invitation.